but like I said, I was looking forward, of course, to meeting myself, and I'm glad you met Janine today. And did you get a copy of our contact sheet?
Yes.
Okay, perfect.
And Kaylee, the nurse, she was adorable.
Wonderful. Good. Yes, ma'am. Yes, ma'am. Well, I wanted to, because I know that I think you may have my chart connected as well, but I just wanted to bring a copy of the scan report too. And,
Yes, thank you.
physical printed copy for
Yes.
you as well.
Thank you.
Well, like I said, I know that Dr. Maxwell was able to share a lot of insight from a surgery perspective as far as the results
Yes.
from your scan and your
Yeah.
treatment so far. And so,
It was a hard day yesterday.
yes, ma'am, I can understand. I wonder if, because I know that you've been getting your treatment, so far chemotherapy wise back home.
Yes, not
And-
gonna be all that.
Right, yes, ma'am. And I wonder if you could share, because I know that side effects have been an issue, especially early on with the treatment. Well, so just curious about, with your last cycle, what was your experience like? And what has been the biggest side effect or issue so far?
Probably after we got the oxyplatin, whatever. I'm an accountant, I can't pronounce all those words, but after they stopped that, I was much better
Okay.
with the chemo.
Yep.
And of course now I've been off of it for almost a month. Of course I'm fine, but I can tell
Yeah.
this is changing, so I know we're gonna have to get back on it, so just gonna have to do it.
Well, I was just about to ask if, over time, since, you started your treatment, have there been things you can see changing in terms of, just from the cancer, like symptoms you might feel from?
Well, I've really had,
pain?
I have not had any pain
Okay.
up until this week. I don't know if it's the traveling, but I'm starting to feel not severe pain, but discomfort. I was like, okay, I've got pancreatic cancer, I've got cancer. But I really, other than the chemo, I hadn't. So, feel fine.
Okay. And so as far as you mentioned work as an accountant, is that right?
Well, I'm retired now.
Retired. Okay.
Yeah.
Okay. Gotcha.
Which I love.
Yes, ma'am. Now, outside of the treatment or the impact of treatment itself, have you found, what's your experience been in terms of energy and just?
Well, I'm
Do-
really
do-
tired the first week after the chemo. I'm just tired.
Yeah.
And fatigued. But after that, I start feeling really good, and then
Okay. And then it goes back. Yeah. I hear it.
I say y'all slap me again with another chemo. But
Yeah.
I know you're doing what we need to be, what we need to do.
Right.
So I'm trying really hard. I think I've tolerated it after we dropped that
Sounds
first.
like-
Yeah,
Mhm.
after the first two treatments, the treatments after that, for the first few days, her appetite was very low. So she had problems, her appetite was so low, she didn't eat very much, but that gradually got better.
Right. Yes, sir.
But the energy, the low energy was throughout the whole week after.
Yeah. It kind of goes up and down depending on where, when you have the infusion.
Right. With that first treatment, which had that first chemo that I had the reaction to.
Yeah.
Now I couldn't eat. I was sick the whole time. The next, I lost weight during that one. The next one, he reduced it by 25%. I did better. I still had the reaction. My throat didn't close up as much, but I still had that reaction with my speech and all. So when he dropped it, but no nausea.
Okay.
And I had no nausea after that with any of the chemo. Actually, I took no nausea pills. He did get, they give you something
Right.
when you leave there.
Right.
But I didn't have to take extra nausea pills or anything. And I've been eating. I've gained, this said 97. I was 98.5 yesterday, so I'm claiming yesterday.
Yes, ma'am. Yeah. Okay, I see. So, I really appreciate you sharing what your experience has been, because that really does help us, in terms of recommending kind of where to go at different points in therapy and what kind of challenges to kind of navigate around as far as, especially, when it comes to personal experience with the chemotherapy itself. Of course, like Dr. Maxwell, and I'm sure Oncology Team at Home has mentioned, chemotherapy regimen that you started off with really is really the preferred regimen of chemotherapy drugs that we use quite often as well. As a medical oncologist who's part of our pancreas cancer group here within MD Anderson, in other words, that is a regimen that we use in our day-to-day practice too, and it's based on studies that have been done really over the last 5-7 years for pancreas cancer that have helped us understand what types of drugs the cancer tends to respond to. The key thing though is to, at different points of time, make sure that we're getting that good effect that we needed to. People can have different experiences though in terms of side effects, and so there are occasions where any variety of reasons that we may need to adapt the regimen as we go along, and kind of the allergic reaction or sensitivity to oxaliplatin is something we see. You're definitely not alone in experiencing that, and just the idea of removing that drug from the regimen and continuing on with the other two is very similar to approach we would have taken as well. But
that's encouraging.
Yeah.
To know.
Yes, sir. Yes, sir. But the key thing still is to see is the cancer responding, and we look for that in a couple different ways. So one is through blood work, like the tumor marker, which is kind of like a temperature gauge on the cancer. The other is physical change, and see is the tumor decreasing in size, is holding steady, are there signs of growth or new areas of growth elsewhere. And Dr. Maxwell and I both share the same impression that I think that the cancer doesn't seem to have had a good response, really, at least in the way that we really intended to, with the regimen you've been getting.
Mm-hmm.
I don't think it's necessarily the having to take out the oxaliplatin, because we can see sometimes that just the some pancreas cancers for this regimen, we can see that some cancers just have this sort of to some extent this kind of innate resistance to the drug. So even when we are able to go straight through with all 3 drugs in the regimen, we can sometimes still see the cancer may not respond in the way that we, as well as we need it to. So with that in mind, just my concern would be if you were to continue, just with the same regimen as right now, that it may not necessarily give us that control of disease we need it to. So
that's what Dr. Willis told us too.
Right. Yes, ma'am. And that's part of why when it comes to pancreas cancer and our understanding of it, there are other regimens of chemotherapy drugs that have also been studied and ones that we turn to if we see that the first regimen we use is not giving us that effectiveness, or if it was effective and then the cancer stops responding to that one. There are other regimens that we have studied, and there's a combination of 2 different chemotherapy drugs that we've had so far. One of them is a drug called gemcitabine, the other is Abraxane. They're both intravenous, and those have really become the kind of the gold standard, if we see situations where cancer is not responding to what you've got so far, the FOLFIRINOX regimen. Our day-to-day approach here would be to use that gemcitabine and Abraxane regimen. And so, in other words, it is considered to be really the standard, by and large for most people. That said, we're always really looking for ways that we can try to improve on what that chemotherapy regimen might do on its own, or look for other options too. And that's where clinical trials come. That's really the passion we have for clinical trials. And I can say that whether we go with the standard option or clinical trial, the goal is definitely the same, to be able to help each individual person who participates in a trial, again, with the ability to just control the disease better than what we may have done to that point. So I wanted to share, of course, kind of how we think about clinical trials and what those may or may not entail, but does that make sense so far?
Yes.
And it sounds like you've maybe spoken about the gemcitabine and Abraxane regimen a little bit. So yes, ma'am. At a bare minimum, that would be, I would say, if we go with the standard option, that would be the combination that I would recommend.
With those 2 chemo drugs, I mean, could you anticipate what the side effects may be on those two drugs?
Yes, sir. I mean,
Well, I got a chart they gave me.
Oh, okay.
oh, you do? Okay, perfect.
At the Montgomery Cancer Center, because
Yeah.
that's what he was, and he referred us to y'all.
Yeah, yeah.
I guess
yes,
he
ma'am.
wanted us to get a second opinion
Yeah.
too, and,
Yes, ma'am.
you know, I would be, if this doesn't work,
Mhm, mhm.
because Dr. Maxwell was talking about it, if that doesn't work, then we might wanna go, we know that, she said it, you know, it wouldn't be right, she didn't think if we didn't try that drug next,
Mhm.
and then look at clinical trials.
Right.
If that doesn't work after 4 treatments, is that right, 4, or?
Right, yes, ma'am, exactly. And so, yeah, I wanted to, along those same lines, kind of outline how we, you know, when and where we think about trials and when, you know, when we turn to those. In terms of, I could say just in terms of what we usually see in terms of experience with gemcitabine and Abraxane, there are some similarities to
Mhm.
what you've experienced so far. You know, things like having tiredness a couple days after
Yeah.
each dose.
Yeah.
We also can see decreases in some blood counts like red blood cells, white blood cells, platelets. There is about a similar chance of things like nausea, about 30% or so people. So, you know, so the idea of having anti-nausea medications infused at the same time
Yes.
that would be very similar.
Yeah.
Yeah.
There are some things that are unique about gemcitabine and Abraxane. Some people can also notice almost like a flu-like kind of feeling for the first 2 or 3 days. Some people may even have low-grade fevers.
Okay.
That's relatively common for gemcitabine, and typically again within the first 2 or 3 days. The other thing I would say for more so for the Abraxane, some people may have a little bit of swelling in their lower parts of the body, usually like feet, ankles,
Mhm.
sometimes
Okay.
legs. So yeah, like I said, there would be things that may be familiar, but also things that are unique to the particular drug.
Okay.
But it is a regimen that we consider, you know, to be, like I said, it's tried and tested, and it's really one that we use as well.
Okay.
And in fact, sometimes that may be the first regimen we start with, and then we go to the one that you just had. So it really depends on the person.
Okay.
When it comes to clinical trials, you know, clinical trials are really designed to be potential options in different situations. You know, we have some clinical trials going on for people who have not started any treatment, and the trials involve basically taking a chemotherapy regimen and adding an additional, you know, investigational research drug with it. Then we have trials for people who've had some form of treatment so far, like let's say a standard chemotherapy, and the scan shows that it's not effective.
Kind of like her case.
Right,
her
exactly,
case.
exactly, yes, sir, exactly. And then we have trials that are for folks who've had, you know, more than 2 forms of treatment. And so all the trials are designed a little bit different to be available as options in different situations. If I focus on the trials that are for, you know, exactly like you said, for trials who, for people like yourself who've had one form of chemotherapy regimen, we have kind of 2 varieties of trials that might be most applicable. So one is that there's a trial that incorporates the same chemotherapy that you would be getting, the gemcitabine and Abraxane, but adds an additional drug on top of that.
Mhm.
Okay.
And that additional drug is, it's not a chemotherapy per se, it's actually an antibody that tries to block a signal that we think pancreas cancer cells are using to prevent the immune system from attacking the cancer cell. So it's more in the realm of what we call immunotherapy.
Yeah, my doctor mentioned that.
Yeah.
Might be a third thing, but you're saying you can actually do that at the same time as I'm taking it?
Right, yes, right. So we have trials that are designed to basically take the same chemotherapy that we would use, but incorporate with that an additional drug. In this case, that particular trial would be one that incorporates the immunotherapy.
Mm-hmm.
Now, the idea behind the trial is that we, you know, this representative drug that in and of itself is not, it's not currently approved for any other types of cancers. One that we haven't used outside of a trial, but the the laboratory evidence behind it tells us that it tries to stimulate some of the signals that an immune cell next to the cancer cell might use and activate and attack the cancer cell. So we have, that as an example. We have another trial that very similarly, it's for folks who've had one form of chemotherapy, and if the scan shows that that's not effective, and we have a trial that where people who enroll will be in one of two groups. So one group of folks will get the standard chemotherapy, so in this case the gemcitabine and Abraxane. The other half of folks will get not a chemotherapy drug, but what we call a targeted therapy drug. It's a drug that blocks a signal that most pancreas cancer cells are using to grow. Your oncology team at home may have mentioned the KRAS gene. It may have seen that.
I have
Work
that
them up.
mutation, that's what she just told me, wasn't it?
Yeah, exactly. So
Wrote it down.
exactly. So most pancreas cancers have that mutation, and it's part of a.
Strange.
Yes, ma'am. I mean, it's a normal gene, but when that gene is affected by the mutation, it kind of, you think of the gene as being like an on and off switch. That mutation leaves the switch stuck on, and it sends a signal to the cell to grow. Now, it's been a long time that we knew about that gene and the mutation and what it does, but it's really only been within the last 2 or 3 years that we finally come across drugs that have the ability to block that signal, or the potential ability. So one of our trials is basically saying, okay, for folks in this situation, we know the standard option, gemcitabine and Abraxane is one, but it's alongside it is testing whether these newer generations of target therapy drugs may be, as effective, if not more effective, compared to the same.
Are they having good results from that?
So I would say so far, it's still relatively early, some of these drugs, and they are part of what we call phase 1 or 2. And this one in particular that I'm referring to is actually phase 3, which means the drug has undergone, it's now been about 2.5 years worth
You can take
of.
your mask off if you want. If you're wearing it for us, and if you're wearing it for yourself, you wear it.
Oh.
If you're wearing it for me and Ed, you can take your mask
Oh,
off.
yes, ma'am. No, it's
Okay.
no. I appreciate you. I forgot actually today's the first day we can actually go without
By the
masks,
mask.
which has been a habit. But I was going to say that these target therapy drugs we've seen encouraging results so far. In the sense that from studies going back a couple of years where we saw that they seem to have the ability to control the cancer, even on their own,
Wow.
without the addition of chemotherapy. I would say it haven't been 100% effective, but in other words, we still see there's cancers that may not be as sensitive to it as others. But the results have been encouraging enough that that's part of why the research is still ongoing, and now it's up to what we call a phase 3 trial. So the results of this trial, if they bear out in the way that we anticipate, this could tell us that this target therapy drug could be the next standard option, to eventually start using outside of a trial. So we're just about there where this class of drugs is going to start to make a big impact as far as what options we have available outside of a trial. Because so far it has mostly been chemotherapy. But this is an example of a recent change that we're hopeful that this will be at least a way to extend our options a little bit further. So it's a trial in terms of how the drug works. We do have confidence in. Of course, it's hard to. We don't have the ability yet to predict exactly, how well the tumor will respond. But I can say that is absolutely the intention, is for everyone who enrolls to, if they're in that group, who gets the target therapy drug, to
So
get
how
that.
quick will this be? I mean, I'm into this now, so is there a chance? Is that something you would consider with me, or what are we talking about here now?
Yeah, yes, ma'am. So really the key thing, other detail I would say for when it comes to trials, are that, when it comes to the actual administration of the treatment, and even a trial that incorporates the standard treatments like with gemcitabine and Abraxane, basically where a person enrolls, because of the important need to monitor and do checkups and blood work, that means basically the treatment has to be done at that institution as well, wherever people enroll. So even if you, let's say you were in a group who gets the gemcitabine and Abraxane, or if you go with the other trial I mentioned that incorporates the chemotherapy with the experimental drug together, they would require getting the treatment here, you know, at MD Anderson in Houston. So
It means we need to come out here every 2 weeks?
yes, ma'am. Well, the first trial I mentioned with the immunotherapy drug, the way that's set up right now, it would be a weekly visit actually for the first couple months. Then after that, the schedule kind of relaxes a little bit. But yes, ma'am. I would anticipate on average it'd be roughly around every 2 weeks or so. The trips and visits.
But the gemcitabine and Abraxane, that regimen would be applied first for 4 cycles before we could enter a trial. Am I hearing that correctly?
Well, we essentially at the moment we could decide, you know, that essentially we could take that step of going ahead with the standard regimen and giving it a try for 4 cycles and doing a scan and you know, seeing if it's doing a better job controlling the cancer. If it is, then we can continue that regimen. If it's not, then that would be another opportunity to look at what trials may be applicable, you know, at that moment. If you go ahead with the standard gemcitabine Abraxane right now, the main impact that would have is just that the trials that incorporate that same chemotherapy, we wouldn't be able to pursue those. We would have to look at other options, you know, but just, so there are trials that, for example, don't incorporate chemotherapy, they incorporate just the target therapy drugs. So in other words, we could decide to look at a trial that incorporates the chemotherapy now, or we could, you know, give the chemotherapy itself a try first, and then, you know, look at whether we need a trial later on. So
are you offering this to us, that we could need to think about this if we want to get that immunotherapy and that, or this, can I get into that one?
Yes.
It's doing
Yes,
the
ma'am.
second one that's into its third.
Right, yes, ma'am. So exactly, there's when it comes to clinical trials, there's a whole team of people, you know, involved, and one of the other key folks is our study coordinator, who's a team member who help us, you know, track enrollment onto a trial and all the steps necessary. For every trial, there's what we call a safety checklist, where we make sure, okay, we need to make sure that this therapy is going to be as safe as possible for each person who enrolls. And that means looking at, you know, different sets of blood work, and there are a whole host of factors that we just want to say, okay, this treatment, you know, is going to be as safe as possible for this person. So the reason I mention that is because I'd like to reach out to our study coordinators to essentially take an initial survey of the safety checklist. From so far, what I've reviewed myself, I didn't come across any major limitations or barriers in terms of being eligible. But I'd like to ask the study coordinator to do their review and also confirm that we have an enrollment spot that's ready to go for us. Because that's the other thing that can be challenging when it comes to clinical trials, is that I can say as of yesterday we had spots available. But sometimes, you know, things may change like day to day. So I'd like to ask them to confirm that we're going to have a spot ready to go for us, and if there's anything that stands out as far as from the safety checklist. As long as we have that, then I can also ask them to really send you more detailed information about the trial, especially the schedule. You know, and so there's what we call an informed consent document. It kind of incorporates all the information about the study and about the schedule. And you know, I like to, that way if you have that way you can be able to take a look and say, okay, and you know, definitely no, you know, I would say it's not something I would say, you know, we want you to have to make an immediate decision about right here, right now, but wanted to just give you all the information we can about.
We're actually leaving today.
Yeah.
So, well, this is very interesting and encouraging.
Yeah, yes, ma'am.
Because I kind of felt like, you know, the first chemo didn't work. Now I met a lady, I actually met her husband, and we're very similar in the first one didn't work for her.
Mm-hmm.
She's on the gemcitabine and Abraxane now.
Mm-hmm.
I pronounce something, I'm gonna learn to pronounce that.
Okay.
And, she was getting her scan the same day I did, but her tumor markers had been over 1,000, and then they're down to 500.
Okay.
After being on that drug.
Yeah. That's right.
So it's a sign that
Yeah.
it was working, so I was encouraged. I thought, well, maybe the second one
Mhm.
would work with me.
Yeah.
My doctor told me my prognosis for most pancreatic cancer is 9 months from the date of your diagnosis. Is that right? Is that right?
Well, I would say it's really, it can be sometimes. It really depends on where the cancer is and how it affects people, and whether beyond chemotherapy or clinical trial drugs, whether we have the ability to use things like surgeries, for example. So there's a lot of different factors coming into place. But
Well, we were really hopeful to have the surgery, but I've got lymph nodes involved. So.
There's a lot that we can't predict with a lot of precision, but I would say in our experience in situations where people have tumor or disease that we can't physically remove, most of the trials that's kind of how we've learned it on average, what a person's prognosis might be. There are some trials that tell us the average prognosis may be 9 months. The average tends to be closer to around 13 months actually. So,
Right, okay.
but it's I would say our ability to predict precisely is really
Hard to
limited.
do,
Yeah. As we go along, especially as we see how the cancer responds to different treatment regimens, that helps us be a little bit more precise. But yes, ma'am. What I would say is that be perfectly fine. I would say to head back home, today. But the bare minimum, I would say if we go with any standard option, I completely agree that gemcitabine and Abraxane would be definitely what I would recommend as well. But at the same time, I'd like to reach out to our study coordinators and see if we could do a quick survey to see if which of the trials I've mentioned has spots ready to go, because if we can, because that would be the alternative. And so I can ask them to contact you by my chart or by phone as well.
Did you feel pretty good about those trials?
Yes, ma'am. Yes, ma'am. I mean, especially because the trial that incorporates immunotherapy, for example, it'll also include the gemcitabine and the Abraxane.
It makes me a little nervous in the second one that I could be in the group that doesn't get it.
Well, the chemotherapy, yeah, right. Yes, right. So the other trial, that's right. There'll be two groups. One that gets, everybody gets treatment, but one group of folks will get the standard chemotherapy. The others will get the target therapy drug.
And you don't know.
That's right. Yeah, we don't have the ability to predetermine which group people are in. But that's right. Yes, ma'am. We wouldn't know up until the time that people enroll which group they would be in.
Would I know once I enrolled which group I would be in?
Yes, ma'am. Yeah, absolutely.
Oh, okay.
Absolutely, yeah.
Because I would want to be the one that's got the antibodies, the chance that it would attack that mutation, that I have.
Right. Yes, ma'am. Yes, ma'am. So for the first trial I mentioned, everybody will get chemotherapy, and then everybody will get the immunotherapy drug on top of that. And then in the second trial, everybody gets treatment, but half the people will get chemotherapy, the gemcitabine and Abraxane, and the other half will get the other class of drugs, the targeted therapy drug, which is a little bit more specific to that mutation that we see in KRAS. So, and the reason why that trial is designed that way is because of there was a time where we weren't certain how effective those target therapy drugs would be. But the early trials were encouraging enough that now it's the reason why this trial is going on, because we think that probably these target therapy drugs are probably going to be as good, if not better, than the chemotherapy. Of course, we can't predict exactly, but that's, in other words, our confidence in them has grown, and that's part of why this trial is designed that way, so that people get only the target therapy drug and not chemotherapy, or vice versa.
Oh, so one group only gets the drug, the other group gets the
Chemotherapy.
Ooh.
that's where the trial that targets the KRAS gene, the KRAS
Mhm,
gene.
mhm.
The other trial I mentioned though, everybody gets chemotherapy and everybody gets the immunotherapy drug.
Is that one going good too?
Yes, ma'am. I mean, that also was a drug that it's been under study now for about 2 years. It was early on the case that we only used the drug on its own. We didn't see, we saw some effectiveness on its own, but really not enough that allowed us to continue to use it on its own. It's really has continued only in combination together with chemotherapy. Yeah, we still have confidence how that drug works, and our understanding of it, but not necessarily different from the one that targets the KRAS gene. The immunotherapy drug is one that we have not, we've not found effectiveness in a way that we can use it on its own. We don't have quite that high confidence in it, but together with chemotherapy, we think it can be effective.
Well, it's my life,
Yeah, yes, ma'am.
and I realize unless I do something, I am not going to survive this cancer. So, well, I would be very interested in finding out, and I don't know what we do. Maybe get an apartment or something here. How long does that last?
Yes, ma'am. That's the other. The trials are designed, with a similar thought process to standard treatments. In other words, that as long as the treatments are effective, as long as side effects are under control, the trials allow people to continue indefinitely. So there's not a specific amount of time if people can be on the trial treatment for several months.
Okay. We're not talking a year. We're talking just several months.
Well, I mean, we've had some folks on some of these trials for more than a year. Some of the other folks who have different receiving target therapy drug for that KRAS mutation. I've had some folks almost approaching, more than a year. So it really, trials are always voluntary though, I should say. So people can say for any reason, hey, I'd like to stop participating, and without any reason at all.
So can you, when you send us all this, can you send us information? I'd like to know, is it shrinking these people's tumors? I haven't heard the word cure. I don't know if they can cure.
That's right, yes ma'am. So we've seen encouraging results in terms of seeing occasions where these drugs, either on their own or together with other drugs, are able to shrink down and control the disease, whether that's the main tumor itself or metastases. We have not yet come across a drug or a combination that is able to completely cure the cancer. Yes ma'am, unfortunately.
But
So,
at least you can have your life back somewhat.
right, yes ma'am.
I need to pray about this because, it's every 2 weeks. I don't know. I just need to pray about it.
Yes, ma'am. Yeah.
I'm willing. I want to have my life back, even if it's for a year.
Oh, I hear you. Yes, ma'am. Yes, ma'am. I absolutely want to get you on the most effective and regimen we can. And at the same time, I know it would be a lot to spend that much time here in Houston, and so we do have our social work team does keep a list of extended stay housing resources in the medical center area. There's one called the Hope Lodge that people can apply for a few weeks or months at a time. Sort of things like that. But I know still it'll be a lot, to spend amount of time away from home.
But would we know, so y'all would test like we do now, we go on in a few months, scan me, is it worth me staying in?
Exactly right, exactly.
Okay.
The goal is to always make sure that therapy, first and foremost, is giving us the benefit for each person who enrolls. And if it's not, then I would be the first to say, we need to do something different, try something different. So the trials incorporate things like scans every 8 weeks, more or less, plus the tumor marker blood test.
Wow. I'm real surprised because Dr. Maxwell made it sound yesterday like I would need to have 4 weeks of, not 4 weeks, 2 months.
4 cycles,
4 cycles, of that drug, and then look at clinicals. So you're saying I could start right off with the clinicals?
Right, yeah. And it depends again on because we do have some trials that that say, they're for folks who've been through 2 other forms of standard treatment first. But yeah, there are trials now that incorporate the option of, you know, being available for people who've had just one form of chemotherapy
That
first.
didn't work.
Yeah.
Okay.
So she was probably referring to the ones that are for folks who've had more than two, yeah.
Well, I know I don't wanna wait a long time, cause I can
Mhm.
tell since I've been off the chemo, it may not have been shrinking it, but I'm starting to have some discomfort, and I hadn't had that.
Right.
I've had none of that.
Right, yes ma'am.
So I know that it's growing, that it's changing, and it's in my lymph nodes,
Mhm.
which means it could get into other parts of my body. Right now, we were looking at the scan a while ago, my liver's still clear,
That's right, yep. Yes,
so
ma'am.
I'm still,
That's right.
well,
Yes, ma'am. No, I absolutely agree. I mean, I would just say the main thing to just keep in mind is that this wouldn't necessarily be the only opportunity to look at a trial option, you know. So if I have a chance to look at all the information and you know, and talk together as a family and pray, I would say if ultimately you decide to not pursue a trial right now, that's completely understandable, and you would still be able to go ahead with what is the gold standard, you know, treatment still, you know, which is the gemcitabine and Abraxane.
But we could go that path
Mhm.
and then, see how that, see how the results are from that,
Mhm.
and then decide about a trial.
That's right,
correct?
exactly. So that would be perfectly fine path to take, yeah. So, I don't want you to feel that, now would be the only time necessarily to think about a trial. We could,
So, I'm
so what
hearing
he said, I would have this chemo, gemcitabine
gemcitabine,
Abraxane, and I would have a drug, if I did the first one, the
Mhm.
immuno drug.
right.
And then the second one is really the one that they're very interested in, having the, so I probably wouldn't qualify for that then if I'd already had the vaccine,
Gemcitabine.
Yeah, gemcitabine and Abraxane, cause they want you to do one or the other.
Right, yes ma'am, yes, ma'am. That is right. But there are other trials, like Dr. Maxwell was referring to, that you know, are still options for people who've had, you know, gemcitabine Abraxane before. Is just that those trials basically, rather than choosing between the trial drug and chemotherapy or combined with chemotherapy, it would just be the trial drug by itself, which
Okay.
could include, you know, we have trials incorporating those target therapy drugs, which is that everybody would receive the clinical trial drug.
Oh, okay,
So,
which is the same thing, drug targeted toward
right, yes ma'am,
stopping that
exactly,
mutation.
exactly.
Wow,
So,
well, I'm encouraged, I wasn't expecting this today.
okay, I hear.
I was just thinking you were gonna say, go home, have the Genovax,
Hmm.
take those, and then we'll look at it, so,
Yeah, yes ma'am. No,
interesting.
yeah, yes ma'am, no, and that was, you know, that was my goal, just to kind of outline how we think about trials and looking at, you know, trial options. So, like I said, if you go ahead with the gemcitabine and Abraxane at home, which would be perfectly reasonable, and I think a good option, then we can always take a look in 2 months and see, you know, whether or not we're getting good effect, and if not, then we can look at trials then too.
if we do that for 2 months, and the results are not what we would like, what's the risk level at that point for her?
Yeah, yes, sir. Well,
Does that make sense?
yeah, I would say, I mean, the main thing that we would probably want to look for is just whether the cancer might cause more symptoms for you, if anything, you know, in terms of just the impact on day-to-day life, is, you know, say in terms of discomfort or pain, for example. In terms of, you know, the risk otherwise, you know, that lymph node is in the back of your abdomen, so there wouldn't be any specific kind of risk. I would say I would link directly to that, but.
So do these chemo drugs attack the lymph node cancers?
Yes, sir, yeah.
Okay.
So the idea behind the chemotherapy or trial-based drugs is that they're intended to treat all the cancer at the same time. You know, both
Okay.
the main tumor itself, any metastases we can see, and any cells we can't see. to prevent metastases from coming over.
Is there any reason, in your opinion, the gemcitabine Obraxine would not have a positive impact on that cancer for her?
No, sir, I would say not in a way that we have been able to reliably, predict necessarily. That, exactly as you saw from the other person, Ms. Little, that there are some, folks whose cancers don't respond to the FOLFIRINOX regimen, but they respond very well to the gemcitabine, sometimes vice versa. So
That's interesting right there.
It really is.
Yeah.
Really interesting, so.
But this day and age, the medical field doesn't really know how the individual would react to either chemo regimen.
That's right.
Yeah.
We are trying to really develop better ways of doing that. We have made a little bit of progress with colon cancer in that way, but when it comes to pancreas cancer, we haven't been able to develop at least a reliable test that will tell us, okay, this cancer responded to this specific chemotherapy regimen.
It's a bad cancer.
It just tends to be one that's, yes ma'am, it hard to predict and how it responds and behave in ways that sometimes we don't expect.
Well, we've got a son that lives in Fort Worth, so, I don't know. We just need to, I just really need to think about it,
Yeah.
I don't know what, I wanna say yes, I want whatever is gonna get rid of this mess.
Yes, ma'am.
you know.
Well, how about this? I can ask our study coordinator to go through our initial checklist and at the same time make sure we have a spot available. And again, that doesn't mean that we would be necessarily committing to the trial, but
Yes,
just in a way that we could maybe on top of that give you a copy of the informed consent document, which would just be for you to review and read through. But if at the end of the day you say, hey, Dr. Willis, I want to go ahead with the standard treatment closer to home, that is completely fine, and completely
And to look
reasonable.
at a clinical after we see if this is not working. or
Exactly right.
It's working.
Exactly right. Exactly.
And
But
you,
we would expect those two chemo drugs to either flatline the growth of this tumor or even have further impact on it and make it shrink.
Right. Yes, sir. Yes, sir. Those would be the things we want to look for in the next scan. Either no further growth
Yeah.
or ideally shrinkage. Yeah. Yes, sir.
should we come out here if I do that and have the scans here, or?
Well, yes,
Y'all
ma'am.
tend to like that. I just had a scan March the 11th, but I understand y'all like to do your own.
Right. Yes, ma'am. I would propose that if we could maybe meet up again in a couple of months. Let's say if you do go with the standard treatment at home, then I would suggest that just for an apples to apples comparison, if we could do the scan here, that probably would be ideal.
And
Yeah.
then see,
Mhm.
okay. Well, you're gonna get a hug today.
Yes, ma'am. I appreciate that.
You may even get a song.
Okay.
I like to sing too.
Okay.
Gee, okay.
Okay.
I just don't wanna wait. I don't want this tumor, this left, because she said it was a very aggressive tumor, so I don't want it left,
Yeah. No, I hear you.
just growing anyway. I wanna go ahead and get started on.
I think we need to get started on something.
Absolutely.
Yes.
Yeah.
Yeah.
And
I mean, I
that
can see us going to the rest of this week, but after
Mhm.
that, I think we just gotta start.
I agree. Yeah, absolutely agree. So yeah, that's why I'll reach out to the study coordinators today
Okay.
and see if they can get some information in the next couple days. But if if they say, hey, we may not have a spot available in the next couple weeks, I wouldn't recommend waiting for the trials.
No.
I'd go ahead and
Go ahead and do this other, and then get me ready for a trial.
Right.
Okay.
Yes, ma'am.
Do y'all communicate back to our oncologists back in Montgomery?
Yes, sir. Yes, sir.
Is that-
So, yeah.
Okay.
So
How
we'll-
we go forward?
Yeah, yes, sir, exactly. So we'll send a copy of our scan report and just our visit,
Yeah.
recommendations and everything back to your team.
Okay, so, all right, so I'll find out pretty soon then if I can even be in one of the studies.
Right, yes, ma'am.
Okay.
Yes, ma'am. So
And
just
if
be
I
on the
can,
lookout.
so I pray the Lord would just give us clear direction. That may be our direction right there. Go ahead and do that at home,
Mhm.
then get it here and get in that Hope House, whatever that was,
Right, yes,
and
ma'am.
have a place to stay.
Right.
Okay,
Yes, ma'am.
okay.
Okay.
Whew. I'm glad we got this.
That's
That's a lot lot to take in.
Yes, ma'am,
nowadays.
yes, ma'am, no, I hear you, yes, ma'am, no, it's a lot to think about, but yeah, no, yeah, we'll be in touch with you next couple days as we hear
Okay.
back from our student committee.
Okay.
Alrighty.
And also, you guys will make contact with the Montgomery Cancer Center,
Yes, sir. Yeah,
Dr. Reynolds back there about the gemcitabine or Braxacine
Right,
regimen.
exactly, yes, sir.
I think he had already indicated that's where he wanted to go
He did
next.
to me, and like I said, I got the information on the drug, and then the next thing he was gonna try was the immunotherapy.
Yeah.
So, but if, gosh, if we can do a clinical that's working on something that's working on, I want to extend my life.
Yes, ma'am.
Now, I'm ready to go to meet Jesus, but I can't sing to you if I start crying, but I'm gonna have my first great grandchild born in August.
Okay, okay, that's good.
And our youngest grandson is 8. I want to see him grow up.
Yes, ma'am.
My other grandsons are kids are grown and married and, you know, but.
That's beautiful. And no, absolutely, no, that's really my hope as well, that we teach on effective therapy, keeps the cancer in check, and just doing all the things you love to do, and with family and love.
We really appreciate the time you spent with us today.
Yes,
Yes, sir.
It's been amazing.
it really has been. I mean, I'm really I'm at least a little bit encouraged.
Yes, ma'am.
After yesterday, nothing to do with Dr. Maxwell, we loved her, it's just the news that she had, which she can't control that.
I hear you, I hear
It's
you.
what it is.
Yeah, no,
It's what it is.
I can understand. Yes, ma'am. But no, thank you for being here, and I really a chance to get to meet with you both, okay? So
Yeah.
we'll be in touch with you.
Okay.
Turn that off or something. I don't know if that on.
Go ahead.
The Lord bless